Happy Friday, everybody. Welcome to Sports Medicine with the Robs. I am Rob.
And I'm also Rob.
And today we are talking about the shoulder and elbow, especially with baseball coming back. We're really looking forward to, sports actually being back. Whether or not you think they're safe to return, that's a whole nother monster. But, some of us definitely have jobs now, right? I'd like to introduce our expert in the field, Mr. Mikey Stant.
Hey, all.
Go ahead and introduce yourself, Mikey. What do you do? Where are you working?
Yeah, so I work at the University of Delaware currently with the baseball team and as well as rowing. Background on me, graduated with both the Robs 2016 from University of Delaware.
Represent.
I went to Sacred Heart University for grad school for 2 years where I got my master's, did my GA position up there. And then I came crawling back to University of Delaware. Been here for the past 2 years. We'll be going on my third year this upcoming school year. So that's where I'm at right now. Been working baseball for the past 2 years there. So really kind of gone head over heels into this shoulder elbow baseball lifestyle. So
Mikey's if I ever have any questions about anything, he's the guy I go to. I'll shoot him a text. Hey, Mikey, I can't, why can't I remember this special test? Can you, it's this, and this. Here are the 6 articles related to this special test. And here's where we go from here. I'm like, okay, I just wanted to know what I'm supposed to, what this one thing was. And it's good because I'm always educated when I talk to Mikey.
Yeah, I'd like to give you the inside out every little thing, so.
Mikey doesn't do anything half-assed. From working to everything else is where we're gonna leave that. It's usually an educational experience with Mikey. I'm actually gonna let Rob kind of take away some of the questions. Start with some of the questions this week. I've definitely noticed in the past couple weeks, it's really me talking, and then Rob just kind of chiming in when I feel like letting him.
Yeah,
but this is Sportsnet with the Rob.
People get sick of that pretty quickly.
Dude, I'm sick of myself. I don't know what you're talking about. This is Sportsnet with the Robs, not the Rob, featuring Rob. Go ahead, Rob. You start our question stuff.
Gotcha. All right, so Mikey, real quick, true or false? Tommy John's makes you throw harder, so pitchers should just get it done right away anyway.
False. That's such a misconception, especially. You go in the literature, there's really nothing supporting that. If anything, kids just generally feel better after it. That's really all it is. For whatever reason, that's such a common theme in the high school, middle school age. And, what's funny is that group actually has the best chance to kind of come back conservatively off of Tommy John reconstruction. And, recently if you go into the research, there's this new surgery coming out called the internal brace for the UCL. So they're actually repairing the ligament and then actually putting a brace essentially around it. And that's actually starting to show some promising results. Obviously, it's got to be a very specific UCL. That's got to be more of your high grade partial tear UCL. If UCL is blown, it's blown.
Right.
Go
ahead.
So that the bracing mechanism you're talking about, is that going inside the body, around where the UCL joint would be?
Yeah, it's still surgery, but it's a 6-month recovery as opposed to a 12-month recovery.
Yeah.
That's your typical ligament tendon repair recovery.
You're back and ready to go.
So you're not waiting for a ligament a new ligament to revascularize and then have to then go through all the stress and whatnot.
So it's similar to the ACL scaffolding research that we were kind of looking into back in the 2015, 16 era.
Yeah, I'm not as familiar with that stuff, but I remember they were trying to get into it on the ACL.
People saying just go get the surgery, right? You throw harder. Unnecessary surgery is just that unnecessary, right? If it ain't broke on the body, don't fix it.
Yeah. So now I will tell you though, there's out of Columbia, Dr. Ahmad, who's actually the Yankees team surgeon, and his group, they came out with this thing called the UCL prognosis score. And so I wish I had it in front of me, but I can't remember what it is. But it's pretty much are you a pitcher? What your MRI show? And then it's a point scale. And pretty much if you score above a 10, it's just get the surgery. You're not going to respond through conservative management. If it's a below 10, it says, all right, you have a better chance to respond through conservative management.
Now, was the reliability of that study pretty good?
So it wasn't a study.
Okay.
Yet. It was like, it was never a study because I remember it was one of those weird things. I don't know if you get Google Scholar alerts or whatnot. So it was one of those things that popped up, and it was like a poster, like it was a PDF of a poster at like an NATA or a conference or something. So it was a very small scale study that they probably just looked back at some of their records and whatnot. But just one of those tools to have.
So back to the bracing surgery you were talking about. How long have they been doing that? How long have they been? How long has this been around, kind of thing?
I wish I could remember the doctor's name, and I'll have to send it to you guys because I gotta go back and look for it. But there's one doctor particularly. He's in Alabama. Like he works at ASMI, which is like that's where Dr. Andrews comes out of. So he's kind of in partnership with him. They've done it before. It was just the success on it before wasn't that great. So, and I was like, don't hold me to the dates, but it was like 80s when they started doing the research.
A while ago.
It didn't work.
Yeah.
It did a while ago. So then this guy's kind of revived it, and the numbers are getting better.
Okay.
And so a lot of this research was in the past 5 years, which means you won't see it again for another 20. So like that's kind of like you won't start seeing it be a regular thing. And, it's not really going to affect too much. I work with college age athletes, and a lot of the times by the time I get them, they're damaged goods. It stinks. There's kids you get that just come in and it's like, yeah, I'll be honest, my elbow hasn't felt right in 3 years. And it's like, great. And those are usually the ones that end up, having to get the UCL reconstruction. But the target for that surgery itself is like the high school, younger age.
Yeah.
Yeah. And I think the problem is that the Tommy John reconstruction itself is actually a very successful surgery.
Right.
Out of Dr. Andrews, James Andrews, in his own study, obviously high-level surgeon, it was like a 91% success return to previous level of activity. And so there's also this sense of like, well, if this works,
if it ain't broke, don't fix it.
Yeah, exactly. So
well, and that. I'd be curious to see, because you always hear like, oh yeah, I'm throwing harder than before I had the surgery. I'm throwing faster, throwing better. I'm wondering if like that's just due to formal rehab, formal training in arm mechanics, biomechanics.
Yes, that is easily the biggest aspect of why they're throwing harder. It's just, oh wow, I have this lower trap muscle in the back. I have the serratus anterior muscle. I have these rhomboids. Oh, when I actually when I feel that part of my back activated, I feel like I can throw the ball harder. And, then you get a physical therapist or an athletic trainer who's seeing them regularly, and, you start being able to work with them a little bit more. Pitching coaches, you get a good one and he really knows what he's talking about, especially on that, the arm care side, as that's the buzzword, arm care. I feel like nowadays when it comes to, stuff like that. So you get one of those good ones. The next thing you know, they might be throwing harder, but it really wasn't because they got a better ligament. It was because they fixed everything else.
They fixed everything else down the chain.
I always, for my athletes, whenever they get UCL reconstruction, I call it a total reset. We're hitting the reset button on you. We're gonna get a whole year to actually fix, your hip range of motion, thoracic spine range of motion, shoulder range of motion, actually build appropriate rotator cuff strength, eccentric rotator cuff strength. All that. You're
looking at the whole athlete versus just the elbow.
Yes, and that's probably the biggest thing. It's like, the elbow in the end of the day is just that's the end result of everything else.
Right, everything else. It's the end domino of everything else. Right.
Yes.
So, Mikey, you talked about Dr. Andrews and his success rate, and obviously that's going to be high in most surgeries he does because he knows more about the human body than all three of us will probably forget in a lifetime.
Yeah.
Who around here have you seen decent success rate with some of the guys that you've sent out for surgeries in this area?
Yeah, I mean, we actually send all our guys to Philly's doc, Dr. Zakati, who he's actually he actually does the research more on the MRI and the ultrasound side. So the gold standard for UCL imaging is actually going to be a ultrasound guided test.
That makes sense.
And it's actually, you put them in a valgus force brace and you measure the difference from each side. I don't know the values off of my head, but that's going to actually be more predictive than any other testing. But you can also do an MRI with a arthrogram to also diagnose. But yeah, that's where we typically send.
Okay.
And obviously he's been doing it for ever.
And of course, there's also plenty of other competent doctors around the area too. Like, I mean, just trust your doc.
Right. So close to Philadelphia, it's
a no-brainer. Just send them, right?
Yeah.
Yep, exactly. And
Dr. K probably knows. Dr. K probably knows like everybody in the profession anyway. So it's like, oh, I can call this guy. Get it, Dr. K. You literally know everybody.
For those not in the know that didn't go to Delaware, because we actually try to reach a bigger audience than Delaware. Dr. K is Dr. Kamitsky. He's our clinical. He was our director of athletic training for the education for University of Delaware. Does a lot of concussion work. Did a lot of wrote the. Why can't I think of the name of it? Dude, I've been out of work for so long. Like, things are slipping my mind. I got to get back in the swing of things. He wrote the position statement on the ankle. Yeah. Thank you.
You're welcome. I didn't say it, but you're welcome.
I just needed to hear your voice, Mikey. That's what it was. And then so talking about pitchers, what about catchers? They throw just as much as the pitchers. Do you see any big issues in the same issues in catchers that you do with pitchers, or do you?
Yeah. Treat them the same. A pitcher is a catcher, and vice versa. There's I can't quote the article. I feel like it's Hibbert. Can't remember her name. But they did this whole survey of like especially in the adolescent population, like little leagues, high school, like who were most likely to get hurt from like a multiple position type of thing. Mm-hmm. So you think about you have this kid who pitches 3 innings in a game, and then all right, you got to go catch. And those are your kids at most risk of actually developing injury.
Right.
Which makes sense. Like they're the ones going to
be throwing just as much as the pitchers.
Yeah. Yeah, exactly. So, it's they also need to be a pretty big focus on, the prevention side and injury risk reduction side. You get away with it with the other positions like outfielders.
Yeah.
I don't know. The throwing volumes just aren't as much.
Right.
But yeah, you got to treat them the same, and
do you have catcher pitch counts at least at the college level?
No, I want to call it catcher pitch count. So college level, no one's pitching catching. You just don't do it.
Right.
It's just more, and I probably need to be more strict with the catchers, but it's more like, hey, it's a constant reminder being like, you can't just throw through this stuff. And the biggest sign for any athlete, they start getting, my inside my elbow's feeling a little sore, or my rotator cuff's feeling a little sore. That's a sign of fatigue.
Right.
And so that's something that they just have to pay attention to. But yeah, for them, it's usually just a general arm care program 3 days a week at the very minimum to try to get them in. And, we're also blessed here where we have a strength conditioning coach as well, who, really hits the whole body conditioning standpoint and strength and power standpoint. So that just helps here as well.
Right. The whole body approach, I think, is probably your best approach to any rehab. Doesn't matter, ankle, knee, foot, elbow, shoulder, make an argument for wrist and hand, but that's a whole nother special subspecialty. All right. And now so any red flags you look out for, like if you're doing a screen on an athlete, on one of your baseball athletes, anything you're looking out for and you're like, no, you have to 100% be in rehab right now, like any range of motion, shoulder end, because the big thing is you hear right now is, the internal versus external rotation bilaterally, right? What's some red flags you're looking out for to be like, you need to be in this rehab right now?
Yeah, and the buzz term is GERD, glenohumeral internal rotation deficit, and I think people need to back off that a little bit. Don't make that your singular number. So right, you're a baseball athlete, you're gonna have GERD. If you're an overhead athlete, it's gonna develop. It's just, make sure you're comparing bilaterally and, measuring that. So the numbers in the literature, 20 degrees. If it's greater than 20 degrees compared to the other side for internal rotation deficit, there's a 2.5 times increased risk of injury. That's an old study, like 2003. That's kind of carried throughout. So my definition of GERD is 20 degrees loss. But you also have to make sure, look at the total range of motion. If say you're a 50 and 120, 50 internal, 120 external, and the other side is, do the math for me, how you equal 170, 71 and whatever. I'm bad with math right now. 70 and 100. Like I'm probably not going to be too concerned about that app. But, if the total range of motion is actually greater than a 5-degree difference, that's actually an increased risk of injury for a baseball athlete at the very least. You see in the literature all the time, they mention all overhead athletes, but that study was only done in baseball athletes, but they just kind of throw it everywhere.
Blanket it. Yeah.
They blanket it because, baseball ends up being the most researched
sport. So so you're not necessarily looking for a internal rotation deficit. You're more looking for a total range of motion deficit. So yes, a 5 degrees range of motion deficit would be a bigger flag than, say, like a 15-degree internal rotation deficit.
Correct.
Okay.
Yeah. And, a lot of times you could probably, I don't know how familiar you are with like the Postural Restoration Institute or whatnot, but what I'll kind of do a Postural Restoration Institute test where I'll get them diaphragmatically breathing and getting a little left hamstring activation. According to them, that's going to help. Diaphragm's going to help kind of, parasympathetic nervous system response, loosen up that musculature. Left hamstring's going to correct that pelvis position, so then the scapula can glide on the ribs a little bit better. And if I can do that test and their arm just like falls, then it's really not a concern for me. There are definitely some times where, you can chalk it up to that internal rotation deficit as maybe being a possible issue. It's just you got to make sure you're actually measuring. If, the big thing is you can't just take one kid's arm, just say the right-handed, you look at nothing else, and you just pin, push down, and go. That's it. It's never going to be just that, because at the end of the day, baseball is a full body sport. Like, so to chalk it up to just, that shorter range of motion is it, I'm never going to do that. But, those are red flags. It was actually by Kevin Wilk was where that number 20 degrees. Oh, I'm sorry. That's Major League Baseball. Shirley et al. Was 25 degrees in high school athletes. So for high school athletes, goes actually increases. But there's actually another study out there that says those without internal rotation deficit were more likely to get hurt. And the reason for that was that internal rotation deficit may have actually been a protective mechanism for it.
Right.
So
body acting.
Right. And so just some things to think about, at the end of the day, you never chalk it up to one range of motion. But yeah, internal rotation greater than 20 degrees on the dominant side compared to the non-dominant side is where the literature will tell you to go. Total range of motion, 5-degree difference. And then also an external rotation loss of 5 degrees is also, when compared to the left side, is another number that people often look at. But obviously don't make it that singular thing.
Right. Don't you're right. Have a all-encompassing versus just
exactly.
One. Right.
And I can go into like my screen that I do with all my baseball athletes. I do the short range of motion. I also do the cross arm range of motion as well. And I don't, once again, it's kind of more just make sure it's like, whoa, you've really changed over these past couple of weeks. Like what's going on, what you do throwing wise. Right. But I put a little more stock into like, I do a scapular assessment. It was originally by Kibler et al. And then McClure et al. In 2009 came up with a grading system for it. It's a 1, 2, 3. So depending on their weight, if they're below 150 pounds, they use 3-pound dumbbells. If they're above 150 pounds, they use 5-pound dumbbells. And what you have them do is just, they take the dumbbells, they go overhead, come back down. And all you're doing is looking at their scapulas and you grade it. If it's a 1, if, normal scapular movement, right? Normal scapular humeral rhythm. It's a 2 if you see that inferior angle kind of pop out a little bit as they go up. And then if they come back down, you see, a little bit of that scapular winging. And, it's a 3 means scapular dyskinesis. So that's your jacked up kid. That's your motor moron. That's when, you just get a shrug and it's all over the place. But does
that one just, sorry, Mikey, you can finish.
No, you go ahead.
So with that one, when you're doing the screening, is it just you're just doing the flexion motion, or are you doing any abduction motion with it?
It's supposed to be flexion and abduction, correct?
Okay.
But yeah, I use that as like a little grading scale, kind of see where people are at. Surprisingly, baseball athletes aren't as bad as you think they are, at least by the time I see them at the collegiate level. But I'll tell you what, swimmers, like they are brutal to look at sometimes.
Well, I think you pinned it. Like all the research is on baseball players. All the focus is on baseball players. Like nobody, unfortunately, nobody's like swimming. Like they don't
forget about the swimmers, the tennis athletes, softball. So like you just get some of these athletes that walk through the door, and it's just like, where did you come from? Like, how has no one seen this before? No wonder why your shoulder hurts. Like, so, but yeah. So I don't get too many threes. I get a lot of kids hanging out in twos, and to be honest, I don't see. There's more research on that to say 33. So like overhead athletes, can't remember numbers, but it's pretty much half of them or 33% of them have like asymmetrical scapular movement and no pathology. So like maybe once again you go back to that, is that just a natural adaptation for the sport? And that's just something you gotta look into to see if it actually is, or I still put stock in not so much working on the movement and whatnot, but you gotta realize, all right, this kid probably needs a lot of low trap and straight anterior work, endurance work, because they've probably never worked on actually activating those muscles before.
Yeah, and I mean, I don't know what teenagers like. Yeah, let me like young adults like. Yeah, let me just activate my serratus anterior. Let me pen down my scapula. Like, that's not a natural thought process, right? So I don't blame them for not knowing that.
Oh yeah.
So Mikey, how do you guys handle pitch counts then? Do you guys use a certain system? Is it really just somebody just sitting there and checking off how many pitches are thrown? Because I know, obviously not at the high school that I'm at this year because we didn't have a baseball season. But the high school I was at previously, we had a program on like an iPad where somebody on the bench would just check off through this pitch, and it would have the tally up there. And luckily the coaches were good that they kind of stayed on top of it, but obviously I would stay on top of it as well. Do you guys use anything like that, or how do you guys run that?
Yeah, so I mean, I'm usually not involved unless it's someone who's recovering from an injury. That's usually all pitching coach, or they have an athlete actually marking it. We have this thing called Synergy. It's kind of like, it's something you have to upload all your video and pitch counts and all that too, for like other teams to view. Once it gets to a college setting, it's not as like, I'm not gonna say it's not as big of a deal, but pitch start. So this is one thing I've recognized in high school too, especially when I talk to my freshmen coming in from high school. A college pitcher, if they're a starter, they're starting once a week. So they are only throwing in a game one every 7 days. If you look at the Delaware high school baseball pitch counts, you're allowed to throw, let's say, what is it? 75 plus pitches,
something like that. Yeah.
And then you can return after 4 days of rest. So for some reason, we're taking a skeletally, muscularly immature individual, and they can come back 3 days sooner than a college pitcher.
Right.
I always send people to pitchsmart.org. Those are probably the best pitch counts, the most conservative, and aligning more with research. If you even take a look, and I gave a presentation on prevention of overhead injuries this past February at UD in our medical aspects sports medicine conference, and I kind of just drew a block of what Delaware High School says you need 2 days to recover. PitchSmart.org says you need 4 days to recover. So I get it, because I understand that there's going to be teams that probably just don't have enough pitching to have all these kids go recover 4+ days or whatnot. But it's gonna have. It's
got to be for the best of the athlete, though.
Yeah, you got to do what's best for the athlete, and not having them. Next thing you know, they see me in college, and it's already, like I said, they're already having issues before they've even come in. And it's like you start to learn, maybe that was happening already, and you just thought, yeah. And what also happens at the college level too is a lot of kids in high school, the level of competition they're facing isn't as good as good as they are. So they're only throwing 85%. So right. Even if they can kind of, coast through and whatnot, and they get to college and start reaching, they start changing their mechanics, and then bam, that's when that incident happens. That's when you feel that pop in your elbow, and history from there.
I think that's definitely why it's important to have like different levels of athletic trainers on like the sports medicine advisory committees and stuff like that. Because I know a couple people on the DSMAC committee. One's a physical therapist, really sports medicine minded guy though, like great guy. Do you know if any of the UDATs are part of that committee?
I would guess yes if it's in Delaware, but I'm not sure.
Right, but like I definitely think there needs to be, not the fact that like we need the college ATs to necessarily dictate how the high schools work, right? Yeah. But like for stuff like that, advice like that, where it's like, hey, we're not even having our college players do this much. Like, why are you guys having your high schoolers do this much? Like,
well, in baseball specifically, it's not going to help going to high school. You got to start little league. Like,
right.
All those pitch counts are jacked up in little league as well.
That's a whole nother.
It becomes something I've even thought about going into is going to Delaware Little League, and I don't know what it would take, but educating coaches on what the pitch, and pitch counts can be hit or miss because depending on how much a kid warms up and all that. But at least signs of
have guidelines
for, like guidelines of the pitching. But then also like here are some warm up exercises that you should have your kid doing. There's a lot of research on prevention programs, in specifically adolescent athletes. It's actually a study out of Japan, 9 to 12-year-olds. I want to say his name is Yamaguchi. I can't remember. Something Japanese, I just can't remember it. But essentially, huge study, over 200 participants. And you should have seen the warm-up program. It wasn't anything crazy. Like it was like some scap activation, some full body warm-up stuff. Something that's very common. And they reduced incident of elbow pain and injuries by 50%. It was 49.5%.
Jeez.
And and guess what? High compliance was for this. It was recommended to do it 3 times a week. High compliance was doing it 1 time a week. So it's really just, and when you get into the injury prevent, and this isn't just baseball, so this is also, there's a handball study, which is probably the biggest like systematic review or randomized control trial, 600 athletes. They pretty much saw like the same results. Handball, you look into handball sometimes for some of this stuff as well for baseball. You saw like the same results where there's a very well thought out prevention program. It was progressed every 6 weeks. And then they went and saw prevention of injuries and whatnot. And once again, it was in that their numbers were lower, actually. And I'm assuming it's because it's that much more intense. But general shoulder injury decrease was like 28%, 22%, something around there. Still good. And once again, what was high compliance?
1 time a week?
It was like just over 1 time a week. Like it was something, it was like, so you're telling me you guys doing this 1 time a week is this, and not that doing more is better in most cases? In these cases, maybe if you did it 3 times a week,
that number would skyrocket.
That number would skyrocket. Who knows? Because I guess apparently it's hard. What gets me about those studies that people were actually honest about answering how many times.
Right. Yeah. How many studies have you looked at or done where like, everybody's like honest about their compliance?
Yeah, I know. So that was interesting, but it's almost like it comes down to educating the little league coaches about like that, and then educating. There's a study out there. If a kid throws through fatigue, so kind of what I talked about before, if they're tired, elbow soreness, shoulder soreness, there's a 36 times increased chance of injury. 36. That number is huge.
Yeah.
And so it's just like if a kid comes up to you and tells you, my elbow kind of feels sore or whatnot, even if there's nothing going on, just don't let them throw.
Just let them rest it.
And so the problems that, there's such a culture of go through pain and throw through pain, and that football mentality of go through pain, and it doesn't match the sport of baseball.
I've seen there was a popular, I think it was a Facebook post going around, but this dad making his daughter pitch in softball pitch when she was tired. It was like 95-degree heat. I'm like, why? Like, what are you getting out of that, right? And they had some heartfelt message about pushing through, whatever. Yeah. And you know what? I definitely think there's some merit to pushing through, but there's also a line you need to draw, right? A little bit's okay.
It's got to line up physiologically.
Correct.
Like, it can't just be all mentally. Like, all right, we got to really put you through the ringer mentally so that when you get to the spot, in case, which like there's merit to it, but and maybe in softball, like the injuries are less from the pitching side and whatnot.
Right.
Like
just because underhand,
which is good. But even then, that's a lot. Especially I don't know how old was the girl, 10 years old. Like why?
Right. Yeah. Yeah. Exactly. Whole nother podcast on athlete psychology. Like that's that's another. All right, Rob, you have any more questions?
So what are your like go-to tests there, Mikey? For like anything with like when the elbow pops up, like what are your go-to tests?
Yeah. So typically, yeah, if it's like specifically UCL that I'm worried about, it goes straight to palpation and Tunnel sign just to make sure there's no ulnar nerve involvement. So you get on the backside of cubital tunnel to see if you can get that flared up or whatnot. Yep, exactly. But otherwise, it's a straight up valgus stress test. Just make sure you're not doing it at full locked elbow. It's got to be at 20 degrees of flexion for unlocked position. You got your moving valgus stress test where you put it up here, you block it, and then you move back and forth. And then you also have milking sign. I don't know if you remember milking sign, but you would put them in that valgus position. You just grab their thumb and you just jack them back. Really, that was actually the origin of that test is actually kind of funny. It came from a Mets player who just like he was talking to the athletic. Yeah, of course the Mets figures. Just going to talk to the athletic trainer, and he was like, it really hurts, and he like crossed his arm, grabbed his thumb, and pulled it that way. He's like, it really hurts when I do this, just that specifically, and the doctor started doing it, and that's how it came up.
Why are you ever in that position to begin with?
Exactly. It was just the guy.
That would have been my first question.
Yeah, the guy was just trying to figure out what hurt. Another thing I look for, extension valgus overload syndrome, which is kind of, that's more of a chronic thing. What happens, that repetitive elbow extension, bone on bone hitting from the olecranon process into the fossa, you can kind of start getting some bone spurs going on. And what we do there is, what I'll do there is actually put their arm in that, in that full pronated position as if they're done throwing. I'll put my shoulder here and I'll push down there just to see if I can recreate the pain or mechanisms that they feel while throwing. There's no research on that one. The other ones actually have some out on. That's more of me just trying to recreate a pain mechanism. But those are my go-to. And then obviously palpation. One thing I always look for, like a guy will come in, if say there's no pop, because there aren't too many, there's actually probably more chronic UCL sprains, like stuff that kind of goes over time than your actual pop and done. Because a lot of guys come in and they'll be like, my wrist flexor is, or they won't say wrist flexor, but it's here, and they get all worried because it's their elbow. I get more concerned when they draw a line. When they go from the medial up condyle and just kind of run down, like, it's like out underneath here. And like, that's going to be more along the lines of, your UCL, your anterior bundle from the medial up condyle to the coronoid process. And when they're kind of drawing that line, that's when I get a little more concerned. And then that from a palpation, I will try to actually get up and underneath to see. Obviously, am I really palpating it? Probably hard to say. But if I can elicit pain in that, that's usually more of a concern for a UCL free.
Okay. One final question for you, Mikey.
Yeah.
What would you rather fight? 100 duck-sized horses or one horse-sized duck?
Oh, it's which would you rather fight? I misread that question then.
Who would I rather fight?
What would you rather fight?
100
duck-sized horses or one horse-sized duck?
Godzilla killed a lot of people in that movie, right? So he could probably handle 100. So I feel like I would be Godzilla in this scenario.
Okay.
So I would definitely take the 100.
But
that is the correct answer.
At that though, I mean, horses aren't angry horses are not gentle, and they are quite strong. Even if they're duck sized, they are still quite strong. Their kicks will hurt.
What do you consider the size of a duck?
I mean, like,
can I get like a cubic footage?
Like
or something
25 pounds, right? Like
25 pounds.
I'm pretty
that's
sure
like a puntable.
Wait, I don't know how big. I don't know how much ducks weigh, so like.
I think I could punt that thing 30 yards.
It'd probably fly 30 yards.
When you think about it, though,
Do I get any weapons?
Ducks are pretty nasty little things. So you give me one horse-sized duck, I'm not going anywhere near that.
Yeah. Especially with the wingspan of a horse-sized duck, like.
Yeah. Like, do I get a weapon? Do I get like
it's
a
probably like John Jones size. Okay.
No, it's you are in your underwear on an island. So I guess the only weapon you have is your underwear, right? Like.
I could strangle it.
I'm slingshotting rocks.
All right. Thank you for the answer, guys. I appreciate it. That's all we have for today. I enjoy questions like that just because it's livens up a little bit of everything. If you like the content, make sure to subscribe down below, give us a like, and leave a comment if you have any suggestions for future episodes. We're definitely going to try to have Mikey on in the future at some point. No episode next week. This is actually going to be news to Rob because I will be going to Tennessee to see some family. So
we're going to the beach too.
So no episode next week, but this one will be released next week. No episode the week after. Yeah. Anyway, we're not filming next Friday, so we're going to be filming the Friday after. But plan for the return, and we'll have a good time. Like and follow, subscribe to all of our socials. And if you ever see Mikey Stant, make sure to just punch him in the face for me and call it a day. On that note, I'm Rob.
And I'm Rob.
That's Mikey. And this is Sports Matters with the Robs. Thank you guys very much.